Hi, I'm Noelle Stewart, and I will be presenting the family portion of our slideshow. We were assigned to multidimensional family therapy, also known as mdft. The assessment includes a biopsychosocial comprehensive assessment for all family members, including screening for domestic violence, substance abuse, and physical and mental health concerns. Each family member will be assessed individually. Records will be requested from past and current providers, both medical and mental health. Other professionals involved in the family's care, including caseworkers, probation officers, and additional service providers, will also receive records requests. The assessment will include observations of family dynamics by taking note of how the family members interact with one another when they are all together. A multi-system assessment of risk and protective factors is the cornerstone of a case conceptualization, which identifies developmental and ecological strengths and weaknesses and serves as the basis of treatment. The American Society of Addiction Medicine, ASAM, recommended level of care is level 1, which indicates outpatient treatment. Framework. mdft came about through a desire to treat adolescents for substance abuse, mental health issues, and behavioral problems. In the early 1980s, Dr. Howard Little saw a need for evidence-based services and care for at-risk adolescents and their families that was not being met through treatment as usual. Little and his colleagues conducted extensive research and tested this new approach for several years. In 2001, mdft was finally implemented. Therapists work in 6 domains: parents as individuals, children, parenting and co-parenting, parental intimate relationships, family relationships, and community and/or basic community. mdft is manualized and contains 3 stages: building a foundation for change, facilitating change, and solidifying change. Goals of mdft include strengthening interpersonal skills, skill building, development of coping skills, goal setting, improving teamwork and unity within the family, reducing substance use and problematic behaviors, strengthening emotional bonds, increasing comfort with accessing and communicating with referral or community resources, promoting pro-social skills and activities, emotional stabilization, increasing self-esteem and self-confidence, problem solving as a family, and increasing school and work performance. Techniques used by mdft clinicians include psychoeducation, skill building, a genogram, emotion regulation, communication, collaboration, individualized interventions, cultural competency, and identification of risk and protective factors. Tools: biopsychosocial assessments, urine screens, training courses, knowledge of developmental factors, communication with community resource and supports, knowledge of attachment theory, and the mdft manual. The goals and objectives of mdft treatment is to reduce mental health symptoms, reduce or cease drug and alcohol use, conflict resolution and problem-solving skills, coping and communication skills, improvement in school and/or work performance, an increase in stability in the home, the development of pro-social alternatives to problematic behaviors, enhance engagement and motivation to improve parenting skills, improve self-esteem, and increase supportive factors and reduce risk factors. The session schedule and times include 90-minute home-based multidimensional family therapy sessions, and those will be conducted 1 to 2 times per week for a period of 6 months. They will include individual sessions, the client and one parent, the client and both parents, the whole family unit, whatever it takes based on the family's needs. The strengths of this treatment are that it's evidence-based, it's effective for a variety of populations, it's adaptable to several treatment settings, mdft increases rapport with community supports and resources, it addresses several needs of families, there is a high satisfaction rate according to mdft.org. It is recognized and respected by drug court and other correctional programs. And there is a high rate of reunification, which means if a child or children has been removed from the home, they are reunited with their parents once the family undergoes MDF and successfully completes MDFT treatment. Weaknesses of this program include the inability to address severe substance abuse. So if a client is using opiates or is using IV drugs, he or she requires an intensive residential level of care, which MDFT does not provide. Also, if there's a very severe mental health diagnosis involving psychosis or actively suicidal clients, those clients cannot be treated by just MDFT. They would include, again, either residential treatment, hospitalization, or psychiatric interventions. The program requires training for the clinician. The clinician must be able to engage all family members and enhance motivation for change. MDFT requires funding, and this funding averages between $2,000 and $9,000 per client per treatment episode. The certification for supervisors, recertification, and on-site training are extremely costly. For the initial certification, it's thousands of dollars, and you're also required to hold a higher licensure, something that's master's level, independent licensure, and they're very specific about the therapist that they select for the program. Resistance and dropout are common for clients who are court-ordered. Typically, our mandated clients pose a significant amount of resistance when they enter a treatment program. So it's up to the therapist to develop a bond, to increase trust, to develop rapport, and increase their motivation for change. If they are unsuccessful, clients will leave treatment almost as soon as they come. Methods of evaluation: drug testing, risk assessments, scaling tools, collaboration with schools, legal system, child welfare services, and other community supports. Global appraisal of individual needs, also known as gain assessments for the adolescents. Timeline follow-back interview. TLFB will look at the client's reduction in substance abuse over time. Severity ratings performed by clinical staff, including the mental status exam and also lethality assessments. The ASAM level of care worksheet is conducted bi-weekly. DSM-5 diagnostic assessments are conducted, and then the client is evaluated to determine whether she or he is still exhibiting the criteria. Methods of intervention: adolescent-focused individual psychotherapy, individual therapy with each parent, family psychotherapy, skill building, education on safe coping skills and refusal skills, developmentally appropriate interventions, problem solving, team building, individual strengths-based interventions, goal setting, parenting and substance abuse education, communication skill building, and strengths-based treatment. The prognosis for the family identified: if all members follow through and complete MDFT treatment, is very positive. This is dependent upon the therapist's execution of MDMFT interventions and ability to engage the family and increase their motivation for change. In part, the expectations for a positive outcome are partially based upon the empirical evidence for this type of treatment. Javier struggles with co-occurring issues, and the family history of substance abuse issues and domestic violence will certainly be challenging to address. If the therapist is capable of providing adequate skill building and education, Javier's risk factors could be greatly reduced. If the focus remains on systemic, developmentally appropriate individual and family interventions, the strengths of the client and family will be drawn out and will elevate the chances for a successful outcome. The first article reviewed involved exploring adapting and implementing an evidence-based treatment with justice-involved adolescents. Young men and women involved in the juvenile justice system are subject to a higher rate of physical illness, mental health illness, high-risk behaviors including substance abuse and unprotected sex. This population also has an alarming rate of exposure to trauma. The outcome of the two other programs designed to address co-occurring issues for adolescents suffering from substance abuse and mental health issues and their families resulted in an increase of awareness for the need to implement a systemic approach and to make MDFT a model for future changes in treatment approaches within the juvenile justice system. The next study was based on the parenting practices within multidimensional family therapy. Due to their developmental stage and its unique characteristics, adolescents require immediate, intensive interventions. The authors of the article conducted a comparative study of the impact of MDFT versus group therapy. It was determined that the parenting practices were improved as a result of MDFT curriculum and related interventions. They provided evidence that this practice was more effective than group therapy and validated the need for further research with larger, more diverse samples.